Okay, so we're going to actually begin looking at the individual rhythm strips themselves. The first thing that we're going to look at are our sinus rhythms. Although technically they're not dysrhythmias, they're part of the dysrhythmia lecture. But before we do that, I want to just kind of jump in, remind us, make sure, number one, that you don't drop that toolbox. You must use each part of the toolbox to ensure that you have an adequate interpretation. And then over here on the left are the rhythms that should appear either on my exam, or these are the ones that you could potentially be tested on over NCLEX. So we'll kind of get into the sinus rhythms and talk about what we should do if we have a client with a sinus rhythm. Okay, so we understand that our sinus rhythms basically means that each part of the PQRST is exactly the same across the rhythm. So we said that we should be able to line up each complex, put it on top of the next one, and they should be identical. The only thing that is going to change is going to be the rate. So we'll look at bradycardias, sinus rhythms, and sinus tachycardias. So our first one, we see just a normal sinus rhythm. Again, each part of your PQRST complex is exactly the same. I could take this image and it lines up perfectly with this image. So make sure that I'm looking at my atrial rate, ventricle rate, PRI, QRS, QT, R to Rs. And of course I can see that my R to Rs are fairly consistent. You can have some small changes, so as long as I ensure that I have a P, a QRS, and a T, and your R to Rs are fairly consistent, you're okay to say that it is sinus. There's something out there called a sinus arrhythmia, which just basically happens because as we breathe, talk, move, our heart rate can change rates, and that's going to affect that distance just a little bit, because remember we said we care only about left to right. We don't care about up or down, and then we see everything left to right is pretty consistent. The big thing that you notice is that here I have 3 big boxes, and this is almost 4 big boxes, whereas this one here is a little smaller, but I have PQRST. Now, so when I Googled normal sinus rhythm, this is what it brought to me, and that's the first thing that I noticed, is that there is a small difference. And as you progress over time, you're going to be able to start picking up on those things. But until you do, make sure you're looking and measuring those R to Rs. PQRST, you have all of that, so this is okay for a sinus rhythm. Here's what it would look like on telemetry. You can see that pretty much that heart rate stays the same. Their heart rate is 69. It's lead 2. ICP, I see that they actually do have a Q here. I see R, I see S, I notice that it's skinny, and then I see an upright T. What don't I see? I don't see any of those big boxes or little boxes that we're always talking about, and that's fine. Totally fine, because when you go to print out a strip, they'll probably print on there for you, or again, like I said in our previous videos, most machines now will have electronic calipers that will actually do the measurements for you. Okay. Bradycardias are going to be anything that is originating from the SA node, so PQRST, but the rate is less than 60. So we understand that the big problem with the bradycardia is cardiac output. Again, I know, I'm a big fan of repetition. So heart rate times stroke volume, 5 volume, equals cardiac output, right? So we know that if I have a change in heart rate, one of the things that's going to happen is your body is going to try to compensate. You can either compensate through increased blood pressure, increased respiratory rate. We want to be able to maintain a normal, stable cardiac output. And again, there's that word stable. So if it's a world-class athlete and their heart rate is 50, I don't care. It could be our little geriatric clients whose heart rate, tends to run low, but they're alert and oriented. What that tells us is that that person's compensatory mechanisms have covered for any decrease in cardiac output. But we still want to make sure that we're looking at the map, right? So the mean arterial pressure. And then if we can fix the bradyarrhythmia, we do. So generally what we see is medications. From just a basic nursing standpoint, beta blockers are notorious for lowering your heart rate. If they're stable, I don't have to do a lot. I go down, I look at my client, make sure that they're satting okay, and document it, document that we did an assessment. If they are unstable, however, because it is a decrease in cardiac output, I want to make sure that I give them extra supplemental oxygen. You can use atropine. All right, so and the rule is if you are at, I use AT because it's atropine. So if your heart rate is at 60 or below, you can have atropine available. Atropine is not part of ACLS. We would give it or put it at the bedside maybe to somebody who's coming back from surgery, somebody who has a known sick sinus syndrome or a symptomatic bradycardia. The problem with atropine, it's an anticholinergic drug, but I would have to sit there at the bedside and push it every 3 minutes. And then we'll have to see if the heart fixed itself. So it's like a patch. It's a temporary patch. You still need to come back and lay down the rest of your nursing care to actually fix the patch. Probably, if it continues to be symptomatic, what may need to happen is that I either pace them, so I can pace them externally, so I put the pads on, we set the pacer for 80 beats per minute, and if your client's heart rate gets below 80, then it's going to shock them. As you can imagine, that probably hurts. Having never been shocked, I won't say that I know that it hurts, but I can imagine. So if we're going to do external pacing, which we would probably do for a complete heart block, could potentially be second degree type 2 because we typically associate those with bradyarrhythmias. I want to make sure that that pacemaker is going to do its job, so we're going to look for pacer spikes on the monitor. But since it's going to hurt the client, I want to make sure that we probably have some midazolam and fentanyl on board. If we determine that more aggressive interventions are going to be needed, then you're going to go down for a permanent pacer, right? So permanent pacemaker. That's not a P, but okay. Here's kind of what it looks like. Again, we see a increase in the distance between my R to R's. but everything else is the same. PQRST, PQRST. This client has, it looks like a little bit of a Q. The PRI is fairly normal. It kind of fits in one big box. If I measure that QT interval, I can kind of see that, okay, that's about 0.44. And then you have nothing happening because their heart rate's only 60 until it's time for the next one to beat. For this particular strip, instead of like having little tick marks, you see that I have these little triangles at the top and bottom that are marking my 3-second segments. And on a monitor, here's what it would look like. Now, there are so many things that could cause a bradycardia. So your first thing is to find out if they're symptomatic, and if they are, then you want to treat the underlying cause. So if they're an athlete, I don't care. If they're hypothermic, I do care. I want to get their body temperature regulated. If it's any kind of medication, specifically it's usually the cardiac medications, you can have changes because of how your body changes position, or orthos. So you can have changes in your heart rate and blood pressure. Severe pain, it's almost a compensatory mechanism at that point. Hypothyroidism, I can't say it. Hypothyroidism. And then, of course, anybody who's in a deep, relaxated kind of state, if you're sleeping. If you're sleeping, your heart rate still shouldn't be 34, but you get the point. So nursing actions, just continue to monitor for low cardiac output, look for your perfusion words, restlessness, agitation, dizziness, hypotension. You can have chest pain because of a decrease in cardiac output. So I believe in our cardiovascular assessment, we talked about demand chest pain, demand ischemia. Make sure that it's not an adverse effect from your medications. So we talk about these, but really all of our cardiovascular medications could potentially lead to some sort of bradyarrhythmia. And then, of course, we want to protect the client from injury. Okay, and again, kind of what it looks like on this launcher monitor. Sinus tachycardia, we see a good lead. You notice how much closer the P is to the QRS and the T. It still fits within that normal criteria. And you can kind of see a little bit of change just with breathing because it's a tachyarrhythmia. Exercise, fever, heat, so heat stroke, certain medications that we would potentially give, epinephrine, levothyroxine, beta agonists, so our albuterols. Again, you can have issues with orthostatics, so either high heart rate, low heart rate, pain, hyperthyroidism as a compensatory mechanism for anemia or hypoxia, stress or anxiety, or worst case, you can have issues with hypovolemia, so fluid volume deficit, hypovolemic shock, cardiogenic shock, heart failure, or your cardiomyopathies, as well as hemorrhage. So you're going to do your assessments. You're going to monitor for your pain, anxiety, restlessness, so your perfusion words. We expect them to be fatigued. Their heart is working harder. We don't expect them to be overly fatigued at 122, but it's that long-term tachycardia. Since you can have issues with perfusion, you can have issues with dizziness and hypotension, chest pain. Chest pain is generally because we lose that fill time. So your heart wants to beat in a rhythmic pattern at a rhythmic rate, a normal rate, If it starts going faster, the ventricles don't stay dilated as long, so they don't fill with as much blood, so you're going to lose cardiac output. So again, you have this kind of demand ischemia. You can have changes in your SpO2, and again, it can be because of medications, and again, our job is just to protect the client from injury. There's not a whole lot of things that I have to do for my sinus rhythms. And most commonly, the answer on any of those practice tests that I see is document and continue to monitor. Or, the nurse is caring for a client with a history of bradycardia. Which medication should the nurse question? Okay, nurse is caring for a client with tachycardia, sinus tachycardia. Which should the nurse perform first? We're going to talk to the client about what they were just doing. And they're going to tell you, oh my gosh, I just ran 10 miles. Yeah, your heart rate should probably be fast. More likely for us, it's our geriatric clients who aren't drinking, who aren't getting the volume that they need, so they get dehydrated. And compensatory mechanism for thick viscous blood is tachycardia. Okay. So here, this is the exact same one I showed you on our primer and our toolbox. You can again see that this P is buried into the T. That's not because that's actually what's going on, right? It's only showing you that because it's a piece of paper in a machine, right? So I understand from a basic nursing standpoint that if I can't really see the P, then I look for my skinny QRS, right? Otherwise, the only thing I need to do is count my rate, because I have a P for every QRS. Heart rate's between 100 to 150. It's a sinus tachycardia. What I want to do is treat the underlying cause. Sorry, the computer is moving rather slow. There we go. So here, we said not all tachyarrhythmias are equal. So I still see that that P is buried into that T. Once they start to get, greater than 120s, then I can actually start to see clients that are probably going to be a little more symptomatic. Because again, we lose that fill time. So the issue is no longer with our heart rate times stroke volume equals cardiac output. The issue is going to be because my ventricles don't stay dilated as long, that I lose stroke volume. So that's why your cardiac output over the long term would potentially decrease. So for us, stress it, stress it, stress it. Treat the underlying cause. You need to talk to your clients. You need to assess your clients. You need to get your set of vital signs to see if they're symptomatic. Get that SpO2. Ask them about their pain. Then we could do a beta blocker. So typically what you would see is either a labetalol. You could potentially see a metoprolol. We want to get that heart rate down. So if the source is because they have an infection, I could give antipyretics. I could make sure that they're getting their antibiotics as prescribed. Of course, if it's because of pain, I can treat their pain. Not just with analgesics, but a lot of distraction and music and all the other non-medical interventions that I can do for pain. But again, that's going to be if the client is symptomatic. If they're not symptomatic, I'm just going to document, continue to monitor, and maybe do more frequent assessments. All right, so what am I? Well, we can see very clearly, and this is something that is absolutely testable, right? I see P, Q, R, S, T. So there's a P wave for every Q, R, S. 1, 2, 3, 4, 5, 6, 70. Heart rate somewhere between 70s and 80s. It's a sinus rhythm. Document, continue to monitor. Same as this one. Nothing has changed here except the rate. This is a sinus bradycardia. You're going to treat them if they're symptomatic. Again, we could potentially give medications to increase their heart rate if it were a critical care scenario. But more than likely, it's probably because they have previous myocardial histories, or it's because we've given them medications that slow their heart rate. I just love going into a client's room, and so they came in with a tachyarrhythmia. Usually it's AFib, and then we've started them on either diltiazem or amiodarone, continuous infusion, and then we forget about it, and then their heart rate gets down into the 50s and 40s. Same, everything here, even if I took just what I recognize as my PQRST, if I lay that over the next one, I know that it's still skinny. This one's tall and skinny, but it doesn't have to be. There's PQRST, the heart rate's between 100 and 150. It is a sinus tachycardia. Treat the underlying cause. That's really it. That's all we have to do for those sinus rhythms. You should be able to very quickly determine if a rhythm is a sinus.